Good evening and welcome. Tonight's webinar is on women's health, tips for ageing well. I'm Sabrina Scandura, the Director of Residential Care and Clinical Governance at Montefiore. I begin today by acknowledging the Gadigal and Bidjigal people, traditional custodians of the land on which we meet today, and pay my respects to their elders past and present. We're absolutely thrilled that we have over 190 people registered for tonight's event. The Montefiore Spotlight Series discusses perspectives on ageing and addresses the issues that affect older members of the community and their loved ones. Each session explores an aspect of ageing experience, including health and wellness, research and innovation, and supporting older family and community members. Tonight, we'll be talking about a great topic, women's health, what we can expect as their bodies age, preventative strategies to aging well, managing chronic pain and injury prevention, as well as medication and alternative health options. This evening, I'm very excited to be joined by three experts in women's health. Introducing Dr. Kerry Lee Milner, who's a Senior Staff Specialist Endocrinologist at Prince of Wales and has admitting rights at St Vincent's Private and Prince of Wales Private Hospitals. She has an appointment as a conjoint lecturer at the University of New South Wales and completed her advanced endocrine training at St Vincent's Hospital and was admitted to the Royal College of Physicians as an endocrinologist in 2006. We're very glad to have Kerry here, who's also completed a PhD at the Garvan Institute of Medical Research, looking into insulin resistance and hepatitis C, and has multiple publications in this area. She has a holistic approach to medicine, and areas of interest include type 1 and type 2 diabetes, thyroid disorders. She also has extensive expertise in osteoporosis, polycystic ovarian syndrome, adrenal parathyroid, and pituitary disorders. So welcome, Dr. Milner. I next introduce Dr. Rochelle Taffel, who has been vocationally registered general practitioner with over 30 years experience and is currently practicing at the Rose Bay Medical Clinic. Rochelle received her medical degree from the University of New South Wales in 1987, going on to study and complete a graduate diploma in paediatrics. As well as providing medical care to the community, Rochelle has been recently involved as a GP surveyor for accreditation of general practitioners over New South Wales through Quality Practice Accreditation. She's currently a Year 1 tutor for the School of Medicine Sydney at the University of Notre Dame, Australia. Dr. Taffel enjoys a variety of general practice, which allows her to follow special interests in paediatrics, women's health, and mental health. We also welcome Natalie Simon. Natalie has been working in the health and wellbeing industry for over 30 years and is a qualified physiotherapist and also holds an advanced diploma in traditional Chinese medicine. Natalie has lectured both nationally and internationally in the areas of postural assessment, exercise rehabilitation, chronic back and neck pain, and injury prevention. Natalie combines her Chinese and Western medicine backgrounds and years of clinical and community experience into her diagnosis and treatments. Natalie is our allied health practice manager at Renew by Montefiore, and she loves educating her clients about safe and effective movements that can enhance well-being and prevent and/or manage pain and injury. Tonight, we are so pleased to see such a great cross-section of different age groups represented in our audience. It's absolutely fantastic to see that our groups of registered viewers ranges from 40 years of age to women in their 80s. So welcome to all of you. We will do our best with our experts to provide you with as much information to cover as much of information as you can to meet the diverse age group needs. But if you do have any specific questions, please use the chat function, which is at the bottom of your screens, and we will endeavour to answer those questions throughout the presentations or at the end as we go. So we'll start off with our discussion. Dr. Taffel, I'll invite you as a GP. You have many patients who seek your guidance. Can you share with us what the key experiences of ageing women are?
Okay, well, ageing really is a complex, multifaceted process, and it varies widely from person to person. It's different between men and women because of different organs, because of different hormones affecting brain function, bones, and other organs. And there are certain key experiences that people commonly report, particularly women as they age. I mean, realistically, hormonal changes start in 30s and 40s, and women talk about noticing fluctuations in their periods, skin changes, certainly the appearance of wrinkles, and certainly their metabolism slowing down. Then as they get into their 50s, certainly menopause, bone density loss, again, weight distribution changes. And by the time they get to their 60s, and realistically by the age of 65, women become far more likely to develop chronic diseases. And these are significant enough to impact on their daily life and their ability to perform day-to-day activities. You know, they develop diabetes, heart disease, and arthritis, and certainly cancer increases with age.
Thank you so much, Dr. Taffel. Dr. Milner, could you expand on the symptoms that women experience at this time as their bodies change?
Thank you for having me. So as women transition into their reproductive years, we start facing a lot of challenges in regards to physical and psychological well-being. And as mentioned, these changes start long before we have any changes in menstrual function. And this is what we call, this period is perimenopause. It's when we start getting a drop in estrogen levels. And symptoms in perimenopause can be quite severe, and I will go into detail about what these symptoms are, but they often are missed because they aren't linked to this period in time because people might still have normal menstrual function. So by definition, menopause is 1 year after your last menstrual period, and menopause, normal menopause with aging, is between the age of 45 and 55. So a lot of patients come to me and say, I think there's something wrong with my hormones. Can you do a blood test to diagnose me with menopause? And we do not need a blood test to diagnose someone with menopause or perimenopause because it is based on symptoms. 80% of women experience these symptoms that I'm going to talk about, and 20% of people have actually very severe symptoms that really impact on quality of life. Unfortunately, some women have these symptoms that extend into their 70s and 80s. So it's important to recognize these changes. We shouldn't feel ashamed to talk about them and to seek help, especially as health professionals out there can offer advice about lifestyle changes or treatments that can help navigate the stage, which is usually temporary for most people. So I'm just going to share some slides. So this is just what we've talked about, the period of perimenopause, which can start in your 30s and 40s, and menopause a year after your last menstrual period, and then our postmenopausal period. So just to discuss the symptoms, there are numerous symptoms, most commonly hot flushes and night sweats, but the physical symptoms are enormous, and they go from weight gain, particularly centrally, fatigue, sleep problems, joint pains, palpitations, dry skin, hair thinning, dry eyes. Really, we could speak about these symptoms for the next few hours. Brain fog. A prominent symptom is, besides the insomnia, is actually loss of libido. Many people come to me because they actually have developed a problem in the relationship due to loss of libido. So all of these symptoms are very commonly experienced in menopause.
Thank you so much. I think there's probably things that we can all relate to, so I will keep an eye out on the chat function. Natalie, I'll come to you. As a physiotherapist and trained Chinese medicine practitioner, what are some common symptoms of aging that women come to your practice for?
Okay, thanks for having me. I mean, as a physio, chronic back and neck and shoulder and knee pain are always common. A lot of women come complaining about having stiff joints, especially in the morning. I also treat a lot of women for stress-related issues like chronic fatigue, low energy, anxiety, irritable bowel, sleep disturbances, and some other autoimmune disorders with the Chinese medicine. And at Renew, a lot of women are starting to present purely for prevention and maintenance associated with aging, which is really pleasing. So as Kerry said, some symptoms of perimenopause or after they've had a diagnosis of osteoporosis, they're seeking some answers and some solutions for that. So that's what I'm seeing at the moment.
Thank you. And Dr. Tuffle, in your summary of what some of us will start experience or have experienced throughout the aging process, when you refer to physical and emotional changes, what approach do you take with women who may be struggling with some of these changes?
Well, I think understanding that while these things happen, it's not normal. It's normal. It happens in their relationship, and there's medications, there's activities, and we can normalize it and make it acceptable for them. For example, emotionally, women often have been the center of a household. Family has grown up, and then there's often a shift in their sense of identity, especially as they retire, especially as children leave home, and it can cause significant changes in their relationships with their husband or partner, and also with other family members. They can become more anxious, they can become depressed, due to both hormonal changes and the life changes that are happening. And women are afraid that in accepting this, it will change them as a person, rather than accepting it and having a greater sense of self-confidence in who they are and feeling more comfortable with who they are as a person. So from an emotional perspective, there are schemes available, such as the mental health care plan, where people can get help, joining groups, talking to other women. It's a really, really important way of coming to terms and getting an understanding of what's happening in their lives.
Absolutely. Dr. Milner, did you want to add anything to that? What type of approach we could take, or what approach you take when you have women that might be struggling with some of these changes?
I think really reassuring women that these symptoms are normal, that what they are experiencing. They might speak to their friends who, may say, I don't have any of those symptoms. Just really to realize that everyone is very different when they go through perimenopause and menopause. And, the severity of symptoms is very different. And really recognizing those symptoms, but then, there are a lot of proactive measures that you can take in terms of improving a lot of these symptoms. So there's a lot of lifestyle recommendations in terms of, things that Natalie will talk about, is exercise, healthy eating, meditation, just a lot of measures and lifestyle measures. But besides that, there are other therapies, psychological therapies like cognitive behavioral therapy, as well as complementary therapies for a lot of these symptoms, which might include hypnosis or acupuncture, and besides that, herbal therapies and a lot of other therapies, which we will discuss later in the talk, which are hormone replacement therapies.
Thank you. Natalie, with aging in general, we've heard over the years the best advice is to keep active. But can you give us practical advice about how to approach exercise, especially if this is something that you're currently not doing or currently not used to doing?
Yeah, sure. I mean, I think you hit the nail on the head when you've just said the word keeping active, because at the end of the day, this is really the key to optimizing our health and our well-being, be it socially, mentally, or physically. It's important to enjoy what we're doing, and just to whatever activity you're doing, you want to enjoy that. That's really important. So I always start by encouraging people to think about what they enjoy, and then what they want to achieve, and to set some realistic goals. So whether it's travel or increase their walking, or if they want to start running, or if they want to play soccer or pickleball or get stronger or fitter, it's important to sort of know what their goals and what's realistic for them. We know as we get older that we lose muscle and bone mass. And as we've discussed, as the hormones start to fluctuate and become unbalanced, we become more prone to things like fatigue and weight gain, inflammation, brain fog, changes in mood, and later prone to falls. So it's very important that we kind of accept and own that we need to do some form of exercise. And I think that's quite a practical point to make, that we first need to just accept it and not deny it. I guess the next step would be to make sure we understand how to exercise safely to avoid an injury. So we need to understand the difference. This is a bit technical, but between sort of deep and superficial supporting muscles. So understanding how to perform stability and mobility exercises. And this can simply involve just learning how to breathe properly through your diaphragm, or understanding how your pelvic floor works. But these are very important fundamental concepts of exercise or activity so that you're safe. And then the main one, which we'll touch on soon, at the end of the day, is all the research is heading towards that we need to start lifting weights as we get older. And that's really an important focus. You know, Pilates is incredibly important for many things with stability and mobility, but a lot of the research is heading towards needing to do resistance training and weight training. And starting from the age of 40, we start to lose our skeletal muscle mass up to 30 or 40% in size and composition. So we can't kind of avoid it.
I'll go out and buy some weights, I think. Thanks for that. Just in terms of some of your clients that might come to you for pain management, how do you approach exercise if they're experiencing pain? Is that a different approach?
Yeah, that's a good question. I mean, pain is very complicated, and people that have had pain for more than 3 to 6 months, we also put them in this sort of terminology of complicated or chronic pain. And it really requires a bit of a multidisciplinary approach. Pain affects people in many ways, social, emotional, financial, physical. It's got big impacts on people's quality of life.
Mm.
So often we need to use a holistic approach or a multidisciplinary approach, which means specialists and GPs, maybe psychologists, physios, or other health providers. We really need to be speaking a similar language. And that language needs to encourage the patient or the client to remain as active as possible, very similar to the question before. There are a number of screening tools which are helpful to understand how the pain affects people physically and psychologically, and this is always a good baseline. We know that pain originates from the brain, and the longer we experience it, the more hypersensitive the body becomes, the nerves and our reaction to it. So my approach with pain is to try and empower the client to understand their pain, what movements are safe, how they can calm their nervous system through either some deep breathing exercises, sometimes acupuncture is used here, and other techniques. Teach them about pacing techniques and what to do if they have a flare-up. Not always to be seeking out scans or medications as the only option, because then that puts them back into being sedentary again, and there's zero literature ever supporting that rest is a good outcome for people with pain or aging for that matter. So generally the main message is remain as active as possible to maintain that quality of life.
Thank you. Dr. Tuffle, we talked a little bit about, well, it was mentioned about screening tests, but how often would you recommend women have checkups, and what type of tests should they be asking, or do you tend to recommend if people aren't asking for anything specific when they come to you?
Women should be checking their blood pressure even from their 40s and 50s, they should be checking their blood pressure and knowing what their blood pressure is and knowing what normal is. They should be having mammograms. Clearly, if there's a family history of breast cancer from the age of 40, otherwise from the age of 50, they should be having cervical screening tests from the age of 25, and the frequency of that will depend if they do or don't have human papillomavirus. Cervical screening tests is the new name for a pap smear, so people get quite confused with that. Fecal occult blood test, checking to make sure there's no blood in their stool from the age of 45, government funded. Reasonably regular blood tests every couple of years to check cholesterol, to check blood sugar, because we know as women age, they're at increased risk of diabetes. Regular vaccinations should be done. I mean, everybody should consider having flu vaccines every year, pneumonia vaccines if they're at high risk. And now for high-risk people, certainly we have RSV vaccination. But realistically, from the age, in my mind, from the age that a woman is perimenopausal, they should consider having a bone density study. Because if you have a baseline, you can institute exercise earlier and encourage exercise earlier and encourage weight-bearing exercise earlier, and then make sure they're monitored so that should they need medication, they can access it earlier before they fall and have a fracture.
That's some great advice. Just on the bone density testing and screen, just a reminder, what was the rough age group for that sort of perimenopause?
Between 45 and 55.
Fabulous, thank you. Thank you so much. Dr. Milner, understanding medical terminology can be challenging, and there sometimes some confusion between osteoporosis and osteoarthritis. So if you could help explain the difference, but also how common is osteoporosis in aging women?
Okay, I'll start with the second part of your second question. You know, osteoporosis is a very common condition in Australia. There's at least 1.2 million people in Australia with osteoporosis, and there's a further 6.3 million people with osteopenia. So I'll explain what the differences are between those two. So of anyone that is older than the age of 50, at least 66% of those people over the age of 50 have osteoporosis or osteopenia. And that translates into about 183,000 fractures or broken bones a year due to poor bone health. So osteoporosis is when the structure of the bone becomes weaker, it's less dense, and there's an increased risk of the bone breaking, or what we call a fracture. And with osteoporosis, these changes in bone density tend to affect different parts of the skeleton. So the places that we tend to fracture or break more commonly with osteoporosis are hips, spine, or wrists. But there's many other sites that can also be affected, such as arms, ribs, and legs. Interestingly, hands and feet are not regarded as osteoporotic fractures. So if you have fractures in those areas, they are not regarded as related to low bone density. Typically, these falls or fractures occur after minimal trauma. So just a simple trip and someone has broken a bone. Mm-hmm. So when we talk about definition of osteoporosis, osteoporosis is diagnosed on a bone density that you mentioned, and this is a very simple test. It takes 10 to 15 minutes. You lie on your back on a bed, and the arm of an X-ray machine moves over your body, and it really looks at bone density in your hip and your spine. Those are the two areas that we look at. And then osteoporosis is diagnosed because it's comparing your bones to a population of young females. So the difference between osteoporosis and osteoarthritis is osteoarthritis also increases with age, but that typically affects joints, and it's related to also wear and tear of cartilage, which also relates to lower estrogen levels. That is a painful condition. Osteoporosis is painless. So many of my patients say, oh yes, I knew I had osteoporosis in my hip, I've got pain. It is a painless condition. You only get pain with osteoporosis if you actually break a bone. Why we want to identify osteoporosis and treat and manage it is because we do know that fractures or broken bones lead to chronic pain, they lead to disability, loss of independence, and also there is evidence that it leads to premature death. So managing low bone density is very important, and there is lots of medical conditions that predispose to low bone density, from overactive thyroids, parathyroid, celiac. There's many medications that can be identified, and also factors like alcohol and smoking obviously contribute to low bone density, but family history is probably the main risk factor, together with early menopause.
Thank you. That's really helped. Thank you so much. And the explaining of the bone density, I think for those that haven't had a screen, that's a great insight. Thank you. Natalie, what type of exercises can you advise for someone who has low bone density?
So there's a new program called Onero, which is a lot of endocrinologists are quite familiar with this because it's an evidence-based exercise program. It was developed based on a Lift More study conducted at Griffith University in Queensland. And like the Lift More findings, the Onero program increases bone mass, improves posture, and decreases falls in patients with low bone density. The results of these studies have shown that 86% of patients increase their bone mass at the lumbar spine, 69% of patients increase bone mass at the hip, at the femoral neck. There's increased back extensor strength as well. A lot of this testing is done 12 months after starting the program. So the program utilises what they call a high intensity resistance and impact training. So you basically just need to lift heavy weights, so you can get those weights going, Sabrina. But there's also an element of impact training. And this Onero program is specifically for postmenopausal women with low bone mass. It can be for gentlemen and for men as well. It's been shown that this high intensity resistant impact training is a lot more significant than low intensity exercise programs. It's also shown to improve some of the functional testing. So when we do an initial assessment for somebody who may come on board and do the Onero program, we often look at their bone density scans. We also do like a timed up and go test and a 5 times sit to stand test, a functional reach test, and a posture test. And all of these things have been shown to improve after participating in the program. We recommend doing it twice a week, and it's basically lifting 3 main movements like deadlift and squat and a shoulder press and some impact. So whether it's a small jump, but it's very controlled and it's very safe. And it would be something that in the past maybe GPs might have shunned, thinking that perhaps it wouldn't be great as to prevent fractures. But all the research is showing that it's very successful and very promising. So that's a very specific strength-based program. 5 repetitions of about 80% maximum. So you start slowly and twice a week, and it's just building and progressively building the load.
Thank you so much. We will definitely come to a few questions shortly. I've got a few questions in the chat, so please continue with those. I'll just go back to Dr. Milner about something that some of our audience would be familiar with, perhaps. It's just around hormone replacement therapies. You mentioned that there might be some therapies to consider. There's some that might have minimal understanding. So if you can tell us a little bit about it, but in particular, if there are any risks of treatment or anything you'd like to share with the audience.
I think the main concern that people have with HRT is the risk of breast cancer. And there was a very large study called the Women's Health Initiative Study, which was published over 20 years ago, which was a study that used different estrogen and progesterone preparations to what we use today. It was also a study that was started, hormone replacement therapy was started in women in their 60s and 70s, which was way after the onset of menopause. And that study did show an increased risk of breast cancer. Because of the study, women have shunned away from hormone replacement therapy, and it's really caused a lot of suffering in women and with really decreased quality of life in women who really experience, you know, significant symptoms related to menopause. So with hormone replacement therapy, risks really have to be individualized. You know, we tend to avoid it in women who have a family history of breast cancer or a personal history of breast cancer. But in terms of, you know, other risks, we really have to evaluate, does somebody need estrogen and progesterone therapy? So people who've had a hysterectomy only need estrogen therapy. And the evidence in women who only have estrogen therapy have not shown an increased risk of breast cancer. It also depends when we start the therapy. You know, it's better to start it soon after the onset of menopause rather than much later, because, you know, when you do start it much later, you are increasing other risks in terms of cardiovascular disease and other things related to not starting it early. It also depends on the form of hormone replacement therapy. So we've got lots of different forms. So it comes in tablet form, it comes as a gel, it comes, so if you put it on your skin as a gel or as a patch, that bypasses what we call first pass metabolism in the liver, which reduces the risk, the clotting risk. And people who have it via this route do not have that risk. And in terms of the breast cancer risk with the newer therapies, we definitely are starting to see evidence that these newer therapies compared to the older therapies have much less risk of breast cancer. And, you know, there's other benefits in terms of starting hormone replacement therapy besides the symptom improvement. There's effects on bone health, cardiovascular risk, possibly dementia risk. And what I would, just to try and help illustrate in terms of the risks of breast cancer, to try and put people at ease in terms of these risks, I'm just going to show you a slide now that just looks at what these risks are. So in this slide here, when we're looking at the risk of breast cancer, we know that there's 23 cases of breast cancer per 100,000 women between the age of 50 and 59 if we look over a 5-year period. So that is, we can see by the top picture here. Now, when we look at women who are on estrogen only and not on a progesterone therapy, which is this group, there are fewer cases of breast cancer in this group. And when we look at people who drink, women who drink two wines a night, they actually have a higher risk of breast cancer compared to the general population or women on HRT. And if people are overweight, this is the biggest risk factor for breast cancer. So if you do exercise, which is at least 2.5 hours of moderate exercise a week, this is a reduced number of cases of breast cancer. So just putting that into perspective, you know, there are other factors in lifestyle that increase your risk dramatically of breast cancer. And, you know, in consultation with medical professionals, each case has to be individualized about starting these therapies. And the aim is to have them, use these therapies for as short a period as possible. Because the longer the period, of use does start increasing risk of breast cancer. And, really trying to get patients over, or women over this period in their life that, they can have significant reduced quality of life. So.
Thank you so much. Those are very interesting facts, and probably a good thing to think about for all of us in terms of just the balance and the effects that exercise can have, plus other things that are lifestyle choices. So thank you. Just in terms of alternative therapies or alternatives to hormone replacement therapy, what are those, and what are things that might be able to help?
So there are lots of alternatives to hormone replacement therapy, and it really depends what symptoms people are experiencing in terms of menopausal symptoms. So if we looking, so firstly, obviously, it's just the lifestyle things that we discussed in terms of healthy eating and exercise, cutting down of alcohol, stopping smoking. But when we talk about hot flushes, night sweats, we do have other therapies, which are herbal therapies. We have evidence for remifenin, which is a herbal medication which can reduce night sweats. There are risks with these therapies as well. No therapy is risk-free. Besides the herbal therapies, we also have antidepressant therapies like SSRIs, which have shown in studies to reduce hot flushes and other menopausal symptoms, help with the mood issues related to menopause. And then we have lots of other medications like clonidine, ditropan, medications that are used for epilepsy like gabapentin, that can be used for hot flushes. And there's a new medication on the market for hot flushes, which is all independent. All these other medications are independent of hormone replacement therapy. So if women choose, if a hormone replacement therapy is contraindicated or women choose not to go on it, there are lots of other options that can be used.
Thank you so much. So we'll come across to a couple of questions that have come through the chat. So I might send this one over to Dr. Tappel, but open floor to anyone that would like to answer this one. There's a question about the government sending reminders for cervical screening, and that after the age of 74, the government doesn't remind us to get screening. Should that be something that a person over 74 does go or initiate themselves despite the lack of reminders?
Basically, a cervical screening test now is looking for evidence for human papillomavirus. In the absence of human papillomavirus up to the age of the last cervical screening test over the age of 70, the government does say doesn't send reminders, and because the risks are low. However, if somebody has symptoms, if they have discharge, if they have bleeding, if they have discomfort, they really should come in, not just for a cervical screening test to look for human papillomavirus, but for a complete screen to have a look at a pelvic examination to make sure that nothing is being missed.
Okay, thank you. There's another question around information or a link for an exercise program. Natalie, I know that we will be sending to all of the recipients that have registered for the webinar some resources, but specifically, shall we encourage people to touch base, contact Renew?
Yeah, I mean, it has to be based on an initial assessment. Everybody's pathologies are different, backgrounds, goals, needs. Everyone's got a different medical history. So everything is based on that initial assessment. And we always try and work with the patient to devise some kind of care plan, a management plan. And it's almost, you know, it's a dual effort. You know, as physios or exercise physiologists or whoever is helping somebody on their exercise journey, it's got to be relevant and practical, and the patient's got to be motivated to want to achieve the goal that they want to achieve. So it's a collective effort. So it's very hard to do a one size fits all. You know, the Anero program is a very evidence-based one size fit all program. It's probably the first time I've implemented something as stringent as that, but it's very much based on evidence. And you know, it's not risky, but osteoporosis, you want to get it done properly. But otherwise, general exercise, you know, my perspective, as long as you understand your body, you know, are you hypermobile? Are you, you know, are you flexible? What's the core motivation? Do you have pain? Do you have pathology? Do you understand how to, you know, stabilize the body? What's your range of motion like? Are you safe to then do, you know, strength work and power and lifting, or participate in the activities that you want to do, whether it's, you know, hiking or lifting your grandchild? So it's very independent. So yeah, come for an assessment.
Thank you. Thank you. Yeah, I really do recommend, I have well, I've recommended my parents to Natalie, and partly because I think there are some great exercise programs out there, but there is a difference between having one that's tailored to complex needs or just to individual needs. So we'll definitely send those contacts through. There's another question, and I'll leave it open to our experts. It's around hair loss. So what can we do to prevent hair loss? That's a great question.
I wish we had an answer to that. So, you know, hair loss does occur as a process in aging, and, you know, worsens during any fluctuations in hormones and with a menopause age. What can we do for hair? It's very difficult. There are, you know, it does require diagnosing if there is a specific problem with hair loss besides just hair loss related to aging. And then there are some therapies that can be used, which typically involve, you know, androgen blocking agents. But it is something that is very distressing for people and quite hard to manage.
It's one of those things that maybe along the line, if someone can invent something for hair thinning or hair loss, even grey hair, I think that would be a good one as well. But they're all parts of aging, so thank you. There's a question here that's quite specific about prolapse. So the question is, if you have a prolapse, can you do weights? And there's a query specifically about the Anero program.
It depends what type of prolapse and what degree of prolapse. The fundamentals for me is understanding the importance of the relationship between the diaphragm breathing and the pelvic floor, assuming this is the sort of prolapse we're talking about. And that's key. At Renew, we have a real-time ultrasound machine, which allows us to see if the patient is doing that correct contraction of their pelvic floor. And if they're not, we'd need to make sure that they started there, because you could make it worse. I talk about breath work a lot, but as simple as it is, if you hold your breath, you increase disc pressure, you increase muscle tension, you can increase prolapse. So it's very important that people understand the importance of exhaling, using their diaphragm before they do any kind of exertion. So once again, it would need an assessment. I'd like to say yes, they'd be able to do some form of Anero, because the key movements in Anero are practical, squatting, shoulder press and deadlift. And you've got to weigh up the importance of the deterioration of bone and muscle loss versus the prolapse. So it's definitely in there as a flag that we need to be aware of and monitor it and make sure that she's safe to progress the exercises. But there's always a baseline that you can start with.
Thank you. Just for those, I've had a question just specifically about the name of the program. So I'm just putting in the chat a response to that. So the practice, the way you work, Natalie, is Renew by Montefiore, but the program is Enero, the main one that we've been speaking about. So I'll put that in the chat, and Natalie, you'll also be sending through some info.
Yeah, you need a license to deliver Enero. So we've been fortunate enough here at Renew by Monty to have obtained that license. So we have the license to run the program between Randwick and Botany. I believe there is one at Bondi Junction, it's a small one, and then otherwise I think there might be some at Hunters Hill. There's not too many. They're building, and they're very protective over the license. They want to make sure that you need to either be a qualified physio or an exercise physiologist to obtain that license and go through some sort of testing. And it's like I said, it's quite protocol.
Yeah. Okay, thank you. There's another question here and open floor, but to answer this one, so is HRT a cure for menopause symptoms?
I don't think that anything is a cure for menopause symptoms. I think it's an adjuvant to helping. I think basically managing menopause is about diet, exercise, wellness, social interaction, as well as symptom control.
And really specifically to the symptoms of menopause, you know, HRT will cover a lot of the symptoms of menopause. But if you have very specific symptoms, say just vaginal dryness, you know, pain on intercourse, problems with urinary frequency, then those could be addressed by different, you know, using different measures. So you would use, you know, local lubrication, vaginal lubricants, or very commonly vaginal estrogens, which are very effective in managing, you know, the symptoms that a lot of people experience with vaginal dryness. And that vaginal estrogens are not absorbed systemically like HRT therapy. So there isn't one therapy, because we can use multiple different modalities just depending on what symptoms you're experiencing of menopause. But in regards to that question, can it cure? I must say that women who experience symptoms of menopause that are severe, that impact on quality of life, really come back overjoyed after they've been on HRT. It is the one, I'm not saying that that is the only therapy, but you know, there is a reluctance for a lot of people to go on that therapy. And for people who do have significant symptoms, besides all those lifestyle measures that we've talked about, it really is very helpful.
Thank you. There's a comment or some advice from one of our audience members to say that they've found ginger shampoo bar has helped with hair loss. So thank you. That's always good to share. And there was another question again about hair loss, about whether there is a cure.
I think we answered that we don't have a cure for hair loss, as we don't have a cure for aging and wrinkles and everything else.
Yes. Thank you. So there was a query about exercise. Is there a recommended age to start? I believe this is about the Nero program, but if we take it just general, is at any time is a good time to start exercise, as we've said. But is there a specific program, well, a Nero that you've mentioned, Natalie? Is there a specific time or age group to start?
Yeah, look, prevention is always better than anything else. So I think, you know, when we're at that perimenopausal age is a good time to start, because this is the time where the estrogen and progesterone and the hormones start to play up and have fluctuations and things in our body change, metabolism changes, weight gain, you know, brain fog, a lot of these things start to develop. But it's the time when we start to lose the skeletal muscle mass and our bone mineral density. So yeah, I'd say from perimenopause, all women should start thinking about doing some kind of strength training. We need to pivot from running, long marathons or cycling or endurance type work or purely just Pilates. We can do all of those things. Like you need to exercise based on what you enjoy doing. So Anero is just one component. If you've already got a diagnosis of osteopenia or osteoporosis, this is the program that I would most recommend, because this is the one that is going to improve those measures and those markers. If you don't have signs of osteopenia and osteoporosis, then you can just continue doing whatever activities you like, but think about impact and think about weight bearing. Interestingly, like there's a lot of talk about during perimenopause and menopause, gaining, tummy fat and increasing sort of, our body changing a little bit. But what I've found, especially in the chronic pain space, and as some women are getting older, especially in the demographic that I'm looking at, sometimes I feel like women are not actually eating enough. And that's not for everybody. Some people might need to look at their diet, but I think it's important to have a look at what we're eating. Women do respond very well to plant-based type diets, but we also need to very much increase our protein. We're looking for those amino acids and the leucines to increase muscle mass. So, eggs and salmon and legumes and rice, and these are very important foods. So it's worth thinking about food and diet, as well as obviously, other things like HRT and exercise. But it's very important. If you're going to start exercising and making a change, you need to think about the way you're eating as well. And women are very different to men. So, the intermittent fasting might be very popular for men. For women, we tend to need to eat a little bit more often, especially after exercise and before too.
And I think the other part of that is don't ditch your dairy, because calcium is really, really important.
Yep.
So yogurts,
Right.
cheeses are all really important in a diet as well.
The recommendation is for 1,000 milligrams of calcium a day, which is quite difficult to get 1,000 milligrams of calcium a day in your diet, because people don't tend to drink milk, but just a glass of milk will have 250 milligrams. So that's how, we need a lot of calcium, which, comes from dairy, but also comes from green vegetables, nuts, and other foods. And just back to the exercise point is, don't go from 0 to 100. I've got an orthopedic colleague who said he loves 50-year-old women who are his, he gets a lot of referrals for hip pain and cartilage problems, and because they've realized, whoops, I've hit perimenopause and menopause, I'm going to start exercising, and they start running without building it up slowly. So just to be
and also make sure you're doing your exercises properly. And that's the advantage of this program, in that I'm sure you train people how to hold the weights correctly, rather than injuring themselves and ending up with sore shoulders without doing it properly.
It's a slow progression. The assessments and reassessments are 12 months apart, and it's suggested to do it twice a week. So it is a lifestyle. It's an ongoing maintenance lifestyle, and people will get stronger and lift more, but it's not going to happen overnight. We need to take into consideration fluctuations and how people feel, and if you've got an injury, you need to modify and adapt, but not stop.
Thank you so much. There's one more question, and then we're going to wrap up for the evening. So the question is, how much of our mother's aging experience can we expect to have inherited? I think that's a great question.
I don't know if there's a lot of scientific evidence on that question, but I think we always ask our moms, what experiences they had with menopause, because that may reflect what everyone else, their daughters' journeys may be. But there isn't scientific evidence showing that, but certainly family history and problems that your mom has experienced are very important, because, all the risks of aging, cardiovascular disease, bones, a lot of those issues do relate to if you have a family history or not as a risk factor.
Yes, thank you so much. There are a couple more questions around vitamins and other sort of therapies, but I encourage you to please go to your GP or specialist, and I'm sure that some of those more specific questions could be advised there based on your individual needs. We have nearly come to the conclusion of our spotlight discussion. I would really like to thank our audience for tuning in and participating. It's great to see some questions for our experts. We will be sending a recording of this discussion to all via email, and those that weren't able to watch this live, there will be a recording sent out to anyone that's registered. But please, share your knowledge with women. I think whether you have close colleagues, family members, sometimes it's difficult to talk about aging, and but I think that the more that it's discussed, it's fantastic to hear about what we could do better, or maybe just time to reflect as well. So really, thank you all. We will be sending out some resources as well from our panelists. We're conscious that there is a lot of information out there, but reliable information is what we will be advising, and we will send those through to you as well. I'd like to thank our experts. Thank you, Dr. Taffel, Dr. Milner and Natalie, for your time and your expertise. If you had any final comments, we have a couple more minutes. Over to you, expert panelists, if there's any other final comments.
I just wanted to say thank you for having us, and thank you to everyone who's joined us today.
Thank you so much. We will be sending out more spotlight events in the coming months. Thank you, everyone. Have a good evening.
Bye. Thanks.